Good afternoon. Today I'm going to present some evidence-based preventative therapy in the ICU. My name is Dr. Kathleen Haley. I'm an assistant professor of medicine and an associate physician at the Brigham and Women's Hospital. I have no conflicts of interest to report. So we're going to be talking about some common ICU complications, including deep venous thrombosis, GI bleeding, ventilator-associated events or lung injury, delirium, pressure ulcers, and critical illness-associated weakness. For each problem, we're going to be going over the scope of the problem and then the evidence to support preventative therapy and some suggestions for specific regimens. We'll start off with deep venous thrombosis. Deep venous thrombosis and pulmonary embolism are very, very common issues in ICU patients. Up to 33% of ICU patients in a medical unit had evidence of DVT by an ultrasound study. DVT and PE have significant attributable morbidity and mortality. I'm sure you're familiar with that. However, the exact numbers are positively frightening. An asymptomatic proximal DVT carries a 13% risk of death at 90 days, compared to patients without DVT who only have a 2% risk of death. DVT and PE frequently occur together. Approximately 10% of the patients in the ICU with a DVT will also have a pulmonary embolism. And most concerning, pulmonary emboli are not frequently suspected on clinical grounds. On autopsy studies, greater than 50% of the pulmonary emboli that were identified were not suspected on clinical grounds. So the scope of the problem is quite large. ICU patients have numerous risk factors for DVT, including immobilization. Frequently, they will have comorbidities such as cancer, both hypercoagulable due to the disease itself and also due to the cancer therapies. There are other hypercoagulable states, including the inflammatory state of just being critically ill, increased age, cardiac failure, trauma, and patients, particularly burn patients, all have hypercoagulable issues, strokes, and obesity. There are also specific risks for the care we provide in the ICU, including medications that prevent mobility, such as paralytics and sedation, mechanical ventilation, and central venous lines. So our patients are at risk for very, very serious problems. What's the evidence for prophylaxis? Well, first, the evidence is really good that prophylaxis works. Up to 57% of VTE will be decreased or prevented by prophylaxis. When using prophylaxis, we want to remember that the pharmacologic, so in other words, the heparin-based, the low molecular weight heparin-based regimens are much more effective than the mechanical-based. The mechanical-based can be used if the pharmacologics are contraindicated, but whenever possible, try to use the pharmacologic prevention. It's much more effective. The problem with prophylaxis in the ICU is that it's not used consistently. Only about 70% of ICU patients on prophylaxis were shown to be treated in over 16 studies. And this range was anywhere from 33% of patients to 100% of patients. Rates of prophylaxis use can be increased by having a daily checklist to make sure that the patient is on prophylaxis. However, a lot of times the risk of pharmacologic prophylaxis is overestimated. And so there are opportunities to improve our use of prophylaxis in the ICU patients. Even when we have patients on prophylaxis, it's frequently interrupted. And when it's interrupted, the patient's at higher risk of DVT. Interruptions because of bleeding, because of procedures, because of coagulopathy. So even when it's ordered, a lot of times DVT prophylaxis is not used as it should be or to its best effectiveness. What are the regimens we can use? And a standard reference for this is the ACCP guidelines, which the most recent form of this is from 2012. References are below. The best is the pharmacologic. And this is for both medical and non-orthopedic surgical patients. The low molecular weight heparins and unfractionated heparin. Unfractionated heparin is preferred for patients with renal insufficiency. Orthopedic surgical patients are a special consideration. They will usually use a direct thrombin inhibitor. Dabigatran can be used, but it's an off-label use. Additionally, the selective 10A inhibitors, such as apixaban or rivaroxaban, are approved for use in orthopedic surgical patients. And of course, antivitamin K agents, warfarin, with a targeted INR of 2 to 3 is a standard prophylaxis in these patients. Mechanical prophylaxis, although not as effective as the pharmacologic patient prophylaxis, can be used in virtually all patients, and it can be used on top of pharmacologic methods, which is a good safety net because the pharmacologic methods are so frequently interrupted. There are various types. There are compression stockings, intermittent compression boots, venous footprints. The goal with any of the mechanical prophylaxis is to use them at least 18 hours every day. The benefit is that there's no bleeding risk. The downside, of course, is that it's not as effective as the pharmacologic method, and there can be skin issues associated with it. So just to review a little bit more details about some of the prophylaxis regimens. The low molecular weight heparins do have an advantage over unfractionated heparin in that it's once daily dosing and generally fewer side effects. So it's very effective. And the side effects are essentially similar to placebo, as shown by the Medinox trial. However, there are problems with any regimen, and the problem with the low molecular weight heparins is that it's renally cleared, and that will have some variation among the subtypes of the low molecular weight heparins, but you have to be careful about that. And so frequently, unfractionated heparin is preferred for patients with renal insufficiency, and it's usually not weight-based. And that can be difficult for morbidly obese patients. And so usually for morbidly obese patients, we change the usual regimen to a weight-based regimen. Okay. Unfractionated heparin, it's the grandfather of the DVT prophylaxis, a long track record of very good effectiveness. And compared to placebo, it will decrease the rate of DVT by approximately 60%. It can be used either twice a day or 3 times a day. 3 times a day is more effective, but there will be a little bit more bleeding, and it's not dependent on renal clearance. And so it's the prophylaxis of choice in patients with renal insufficiency. However, like anything, there are complications, and the one that is most concerning for heparin, unfractionated heparin, is, of course, heparin-induced thrombocytopenia. It's fairly unusual, but up to 1 to 2% of patients will develop this, and it does depend. The patients will have different risk groups. Obviously, after cardiopulmonary bypass pump, there'll be a slightly higher risk than in a routine medicine patient, but the number to bear in mind is 1 to 2%. Alternative agents are sometimes used, particularly for patients who are already on these agents for alternate purposes. Aspirin does have a decreased thrombosis risk compared to placebo, but it's not as effective as the traditional pharmacologic methods. And because of its effect on platelets, you do have actually an increased risk of bleeding than the traditional pharmacologic DVT prophylaxis. Similarly, direct 10A inhibitors have also been used, particularly for patients with HIT, although these are off-label use. They're effective. They will decrease the incidence of DVT by 46% compared to placebo. However, they will have a dependence on renal excretion. Aside from the renal excretion, they're very safe. The bleeding risk is about the same as placebo, about 0.2%. And remember that they are only they are only FDA approved for the post-operative DVT prophylaxis and treatment of PE and DVT, but they are commonly used, as I said, off-label for this indication. Direct thrombin inhibitors are approved for patients with HIT, and they include lepirudin. It's available for subcutaneous injection. You monitor it with a activated PTT. Allergic reactions and anaphylaxis are an issue, and so this is not used very commonly. And it can be seen in up to 40% of patients. You can get an antibody to the lepirudin, which is a hirudin derivative. Also, an antibody that is developed will delay the clearance, and so will affect your dosing and the reliability of the prophylaxis, and you may get more bleeding. Similar to other medicines, it has renal excretion. And so for all of these, this is not used very commonly. Argatroban is only available for IV administration, and again, it's monitored with the activated PTT. It depends on hepatic clearance, but be mindful that even if the patient does not have cirrhosis, if they do even have even mild difficulties with their hepatic function, such as seen with hepatic congestion and RV dysfunction, they will have delayed clearance of argatroban. It will interfere with the INR assay, and so the PT will not be reliable. You follow with the PTT. Oral agents such as dabigatran are not approved for DVT prophylaxis, and there's very limited clinical experience thus far with that. So they would not be the favorite agent for prophylaxis if you need to use a direct thrombin inhibitor. There's a lot of special considerations and special populations for DVT prophylaxis. As we mentioned before, the patients with renal insufficiency or frank renal failure have difficulties with anything except unfractionated heparin. Of the low molecular weight heparins, dalteparin has been shown to be safe with GFRs down to 30 milliliters. That's been well studied, but that's really an exception among the low molecular weight heparins. And of course, patients who are morbidly obese need a weight-based adjusted for their low molecular weight heparin. That's because they have a different proportion of lean body mass to fat. And also, if an enoxaparin regimen is used for a morbidly obese patient, the dosing schedule should be adjusted to twice a day rather than once a day. So weight-based and twice a day for morbidly obese if the low molecular weight heparins are used. Additional issues that arise with DVT prophylaxis include patients with a pre-existing coagulopathies. And this is really grossly unfair of Mother Nature for these patients because the abnormalities in coagulations due to uremia or hepatic dysfunction are not protective. However, they still increase the bleeding risk. And so mechanical or pharmacologic prophylaxis is still recommended for these patients, depending on the extent of the coagulopathy or the problems that they have with thrombocytopenia. One may opt to use mechanical means. But again, if you're not having ongoing bleeding, if you think they can tolerate it, the pharmacologic will be much more effective. And the only thing worse than the bleeding that you may get with DVT prophylaxis in a coagulopathic patient is the prospect of having to systemically anticoagulate them with the DVT. And they are still at risk despite their coagulopathy or thrombocytopenia. There's always a concern for GI bleeding and also patients who are actively GI bleeding who are in the unit. Major GI bleeding, however, is only seen in 0.2% of patients on DVT prophylaxis. And when this has been examined, and it has been in the literature, DVT prophylaxis is safe to use in the face even of an active GI bleed. Of course, the amount of GI bleeding would be a consideration, but for patients who are just coming in for serious but not life-threatening bleeds, pharmacologic DVT prophylaxis would be recommended. Patients with spinal anesthesia are at a different kind of risk, though, because they have an increased risk of spinal hematoma. In those patients, the pharmacologic DVT prophylaxis is likely to be contraindicated, and you should probably go for the mechanical prophylaxis. Neurologic patients are also a special consideration. The mechanical prophylaxis is safe for all patients, even on admissions. And you will get a decreased risk of thromboembolism with just mechanical prophylaxis. So it will be effective, just not as good as the pharmacologic. However, the bleeding risk is something that is very, very much on everyone's mind for any of the neurologic patients, because obviously intracranial hemorrhage could be catastrophic. Generally speaking, to summarize this slide, you want to wait about 24 to 48 hours after either surgery or the risk of hemorrhagic conversion stops, and then you can start in prophylactic regimens with a pharmacologic base. Until then, stick with the mechanical, and of course, you're going to be talking with your neurologic and neurosurgical colleagues about the timing to start the prophylaxis with the pharmacologic. So, on to our next problem. GI bleeding. So stress ulcers is a common worry in ICU patients, particularly patients on mechanical ventilation. This is due to the abnormalities in the GI mucosa, which by endoscopy can be seen in up to 75%. However, the reassuring thing is that clinically important bleeding is much less common. In fact, it's much less common than what we thought it was previously. There were a couple of large studies within the past couple of years that showed that, realistically speaking, clinically important bleeding occurs in only 0.2 to 6% of ICU patients. And so the impact of it is very, very less. And so we can be less stringent in our requirements for GI prophylaxis. There are known risk factors for GI prophylaxis. These include mechanical ventilation for greater than 2 days, coagulopathy, older age, sepsis, multi-system organ failure, and steroid therapy. The stress ulcer prophylaxis in the intensive care unit, the SUP-ICU study, was a multi-center blinded study in 33 European ICUs, large number of patients, 3,200, and they enrolled patients, 1,600 to a proton pump inhibitor and 1,600 to a placebo. Comparing results, at the 90-day mortality, there was no difference between the proton pump inhibitor and placebo. The composite outcomes, including clinically important bleed, C. difficile infection, pneumonia, myocardial ischemia, again, no difference. Clinically significant bleeding was less with the proton pump inhibitor, 2.5% versus 4.2%, but this was not statistically significant. The regimens that can be used for prophylaxis for GI bleeding include histamine receptor blockers, either IV or enteral. There are a lot of drug interactions, though, with these medications, so check with your pharmacist. And, of course, the proton pump inhibitors, either IV or enteral. The proton pump inhibitors may give you slightly more consistent protection than the histamine receptor blockers, but either will be fairly effective. Of note, the proton pump inhibitors will interfere with clopidogrel due to the inhibition of the cytochrome P450 2C19 enzyme, and because this medication, clopidogrel, must be activated by that enzyme. There were also concerns regarding side effects, particularly an association with C. difficile. However, as we just talked about with the SUP-ICU study, there was no difference in a composite endpoint, including C. difficile occurrence. Interestingly enough, recent data suggests that just enteral feeding, so starting those 2 feeds early, may be every bit as effective as a pharmacologic approach to preventing GI bleeding in ICU patients. One thing that has really fallen out of favor recently is the sucralfate, which is only enteral. It's very difficult to use because it's very chalky and it has a tendency to clog tubes, and it will also not have the effectiveness as the easier to use H2 blockers or the proton pump inhibitors, and so it is frankly no longer recommended. So what is recommended? Use the prophylaxis only in patients with clear indications: the mechanically ventilated for greater than 2 days, sepsis, older patients, coagulopathic patients, patients with multi-system organ failure, and then stop it once the risk resolves. So on to the next problem, ventilator-associated events. Now, this used to be considered more just focused on infection. However, the CDC realized that it's really hard to define ventilator-associated pneumonia, and that actually there's more complications that are important, even infective, than just ventilator-associated pneumonia. So they broadened the criterion and to say now ventilator-associated events. The ventilator-associated pneumonia subset of ventilator-associated events is defined by 2 days of stable or decreasing ventilator settings, then 2 days of worsening ventilator settings. And it can be possible or a more broad in ventilator associated infection. And it just depends on how sure you are about the diagnosis of pneumonia. Do you have an infiltrate on chest x-ray, et cetera? You may just simply have an infection-related ventilator-associated complication and not a VAP per se, but they're treated the same way. They both have significant morbidity and mortality, and it's frequent complication in our patients on mechanical ventilation, up to 28%. And they will both increase the length of stay in both surgical and medical patients. And there's a significant downside of these things, so it's definitely worthwhile to try to prevent them, up to 76% attributable mortality. So it's a very serious problem in our patient, although the mortality will depend on the causative organism. Resistant gram-negatives are, of course, the worst. In medicine patients, the attributable mortality approaches up to 30%. So even with not a resistant organism, there is still significant attributed mortality. How do you prevent this? The type of suctioning, we've pretty much all changed to closed inline suctioning. The humidifier, the heat and moisture exchangers are better than heated humidifiers. Just change them weekly. Higher frequency changes because you're breaking the circuit will have higher infection rates. And the circuit changes do not prevent infection, and more frequent changes break the circuit, doesn't help, and also just simply decrease costs. So the inline suction and don't break the circuit are the kind of mechanical ways to prevent infection-related problems due to the ventilation. Patient-related issues, prevent aspiration. That's the common mechanism for infection due to the ventilation. And so you have to aspirate infection secretion, so keep the head of the bed up. Endotracheal tubes that have supraglottic suctioning, endotracheal or tracheostomy tubes can be considered, but they are not always easy to find, and they're more expensive to use, but they have been shown to be effective. Maintain adequate but not too high cuff pressure in the tracheostomy tube or the endotracheal tube. Avoid nasotracheal intubation, which blocks off the sinuses and is an invitation to a pneumonia. And maintain good oral hygiene, but avoid chlorhexidine. And in certain populations, GI tract contamination may have a role, but only in selected patients. Rocking beds are helpful, but they're very, very expensive, so they're not available at all places. Of note, early tracheostomy is not effective in decreasing the rate of infection, and this was shown in a multi-center study published in JAMA in 2010. And always remember, if you're going to have a ventilator-associated complication, you need a ventilator. And so early extubation or use of non-invasive ventilation are effective ways to avoid ventilator-associated injury and complications, mostly because the functioning laryngeal reflexes are better at protecting the airway than even the tightest endotracheal tube. One question with preventing ventilator-associated complications in general is, can we prevent ARDS? And the lung protective strategy is a very, very powerful approach to using mechanical ventilation to protect the lung from additional injury. And it may be an effective preventative strategy, even with the short-term ventilation that is seen down in the OR for prolonged surgical procedures. And of course, one has to balance the risk of ventilator-associated injury with the sedation dosing. But if there's any question that the patient is at risk for lung injury, going with the low tidal volume lung protective strategy is a good way to prevent complications. The next problem that we'll be talking about is delirium. And this is acute brain dysfunction with varying degrees of decreased attention, changes in cognition and perception, and it's frequently missed. Bedside screening methods can be important and useful. Examples include the CAM ICU, the intensive care delirium checklist. And there are 3 types of delirium. The most common type is the mix. Almost a little over half the patients will have that. Hypoactive, which is frequently not diagnosed. Well, next category, and then the pure agitated is actually quite rare. Only about 1.5% will have that. About 32% of patients who are awake in the ICU will be shown to have delirium. So it's very, very common. In mechanically ventilated patients, the incidence can be as high as 80%. So it's very common, and it's associated with very bad outcomes. It's an independent risk factor for death, particularly the hypoactive form of delirium. It's increased risk of complications, length of stay, and of course, increased costs. And then once the patients go out to their rehab, because their thinking is not correct, it's harder for them to actually rehab. And so just all along, it's really an awful problem. However, the prevention is quite tricky. The pharmacologic prevention has not been very successful. The studies are very mixed regarding the success with that, particularly in the medical ICU. Some of the postoperative patients have a little bit better outcome with pharmacologic prophylaxis for delirium, but the medical ICU patients, very inconsistent results. The problem also in trying to figure out whether or not the pharmacologic approach is working is that the agitation that is the hallmark of delirium or the mixed delirium is frequently just simply controlled by medication. And so you can't find the delirium because the patient is sedated, which they have to be for safety sometimes, but it's very hard to really know how delirious they are. And it's also possible that some trials that are reporting successful prophylaxis are actually looking at early treatment of delirium symptoms rather than true prophylaxis, since finding and identifying delirium is quite a difficult issue. So the thing that works for preventing delirium is actually the non-pharmacologic. Avoid exacerbating medications, maintain good symptom control, normal day, night, and sleep cycles. Very difficult in the ICU, but definitely aim for that. And whenever possible, remove invasive devices. When it's done as a whole package, such as the Society for Critical Care Guidelines Management of Pain, Agitation, and Delirium, non-pharmacologic prevention of delirium can be very, very effective. And so we should always try for it, even though it can be difficult to achieve some of these goals, particularly the sleep cycle. So evidence-based recommendations, proactive daily assessment to find early signs of delirium, because if you see altered cognition, then instituting those non-pharmacologic means can be very, very helpful, and get them going as soon as possible. And if the patient has a safety risk, or if you can't control your symptoms by the non-pharmacologic interventions, then at that point, add pharmacologic symptom management. Acquired pressure ulcers are another very common problems with a prevalence up to 24%, and they're frequently associated with medical devices up to 41%. It's important quality measure the risk factors, as with many things, age, immobility, pressure dependence, sedation, the body mass index, and renal failure. The way to avoid it, maintain good tissue perfusion, frequent skin inspection, early treatment, because early treatment is effective with the padding, and good turning schedules. Patients are sometimes too unstable for this, and the weight shifts are not as good as the full turns. So whenever possible, go for the full turns. Specialized linens can be done. They do reduce friction, but again, they're expensive. I'm going to defer critical illness associated weakness. It will be in your pack of slides. Again, it's a very important problem. The prophylaxis is, although it's an important problem, the prophylaxis is iffy. And early physical therapy is about our only tool to really try to get prophylaxis for critical illness associated weakness. Take home points here. Critically ill patients are at risk for venous thromboembolic disease. The prophylaxis is effective, but only if we use it. Histamine receptor blockers or proton pump inhibitors are effective prophylactic strategies for preventing stress ulcers. The common denominator in ventilator problems is to avoid aspiration. Environmental controls can decrease the incidence of delirium, and exercise is probably good for everyone. Thank you very much for your attention. Good afternoon.
Thanks so much, Kathy. I really appreciated that. I don't know if you want to do, if you do have one of the questions that you wanted to go through before we move on to the next talk, perhaps one.
Certainly. Question. You have admitted a 68-year-old gentleman with sepsis due to pneumonia. As part of his routine admission orders, subcutaneous heparin is started for DVT prophylaxis. The patient has required mechanical ventilation and pressor support. His pertinent laboratories include a creatinine of 2.6, an INR of 2.2, and platelets of 95. What should be done regarding his DVT prophylaxis? A, the subcutaneous heparin should be discontinued and mechanical DVT prophylaxis started since the patient has signs of a coagulopathy. B, the subcutaneous heparin should be continued. C, the subcutaneous heparin should be changed to enoxaparin since the patient has evidence of renal insufficiency. D, the subcutaneous heparin should be discontinued. No DVT prophylaxis is needed because his INR is 2.6. Or E, the subcutaneous heparin should be discontinued and fondaparinux used instead for DVT prophylaxis. All right, well, that was fast. It looks like many people chose the correct answer. Oh, I see. Wait a second. Oh, we're still having people come on, so. So the answer here is B, the subcutaneous heparin should be continued. And that's for all the reasons that we talked about. The patient has renal insufficiency, so unfractionated heparin is the preferred DVT prophylaxis, and he is still at risk, even though he's also unfortunately at risk of bleeding because of his coagulopathy. Again, I want to thank you for your attention. Good luck on your boards.
Thanks so much, Kathy. And there are many great questions in the chat, but we'll take them later in the Q&A. And if you can stick around, that'd be awesome. So